don't stop. It just stopped. Sorry about that. We'll get this back up. We're going to talk about how proposed changes to the Patented Medicine Prices Review Board regulations framework and maybe more in general could affect patients' access to drugs. Encourage everyone on the line to come up with some questions and to provide some input. I'll be monitoring the chat box at the online as we go through, so don't save them to the end. And we may not get to all of the questions or the themes that everyone wants to talk about, but as many of you know who take part in these webinars, we sometimes take things offline, and we'll get back to you separately if something needs to be followed up. And to be honest, many of the questions and ideas that people bring forward through the chat boxes are excellent ideas for future webinars. So hats off to the Canadian Cancer Survivor Network for doing this series. To remind some people, and those of you who are regular listeners or participants, this is something of a follow-on webinar. We did a webinar on this subject in early June to walk through the actual proposed changes in some detail. This is an opportunity to have a few expert and stakeholder perspectives on these issues. So let's get started without any further ado. Today's participants, I'll be moderating it, and our first panelist will be Wayne Critchley, Senior Associate at Global Public Affairs with the Health and Life Sciences practice. His experience includes leadership roles within government departments, boards, and agencies, primarily in the pharmaceutical sector. It includes a tour at the Competition Bureau, a long tenure as Executive Director at the PMPRB, at the Patented Medicine Prices Review Board, and service as Vice President at the Canadian Agency for Drugs and Technologies in Health. Today, with Global Public Affairs, he works on issues like this on a regular basis, and he'll explain a little bit more when he gets up. Wayne will be followed by Neil Palmer, President and Principal Consultant of PDCI Market Access, Inc., pricing and reimbursement consultancy founded in 1996. If any of you have heard or seen Wayne speak, and some of you probably have, you'll know that he comes with numbers and with experience that's global in nature. So what I like about having Neil here today is that we get out of Canada, we learn a little bit more about how things are done around the world, and then he brings it right back to how it's now working in Canada and some of the proposed changes as well. Neil will be followed by John Peter Bradford, who is a recognized and successful businessman and management consultant based here in Ottawa. Most recently, although I say recently now, it seems like it's been over a year since you started to listen, and I'm saying you as in John Peter across from me. That's the Life Saving Therapies Network, and so John Peter, you can explain a little bit more about that when you start your discussion. John Peter is going to actually lead us into the discussion phase of this as a cancer survivor and a caregiver, and someone whose organization contributed to the Survivor Network's submission to Health Canada on this issue. It'll be great to hear what you have to say and some of the questions that you're going to put to all of us. So let's talk about what we'll discuss. I'll give a very brief introduction to the PMPRB and to the proposed changes. We'll turn it over to the panelist perspectives, and we're going to leave at least 15 minutes for discussion. So what is the PMPRB? Many people don't know what it is. It's a quasi-judicial federal agency started in 1987. It reports to the federal health minister, although its regulatory and legislative legislation is actually part of the Patent Act. So only that section of the Patent Act that deals with the PMPRB is the remit of the health minister. The rest is the responsibility of the innovation minister. It's got a twofold mandate. It does two things. First of all, it regulates prices, or I should say maximum non-excessive prices, applying different tests, and it reports on trends on pharmaceutical use and research and development from the patented pharmaceutical sector. So it fulfills its regulatory mandate. based on a couple of different methods. First, it has independent assessment of treatment's therapeutic value versus alternatives. So it's got a committee that actually determines whether a product is a breakthrough, a substantial improvement, moderate improvement, et cetera, compared to other drugs or other treatments. Second, it uses or applies the prices for the same medications in other countries, which currently include France, Germany, Italy, Sweden, Switzerland, the United Kingdom, and the United States. And they're commonly known as the basket of reference countries, or the PMPRB7. So what are some of the proposed changes to how the PMPRB operates, or its regulations that it actually operates under? The changes that have been proposed by Health Canada, and this was goes back to mid-May in terms of when I started consulting on this, they are suggesting that we add economic factors for the PMPRB to consider, and that would include pharmacoeconomic analysis, so potentially something similar to what health technology assessment agencies and pharmacy and therapeutics committees and others apply, the size of the market, and Canadian GDP. How wealthy is Canada? They also are recommending, I should say Health Canada is consulting Canadians, or did consult Canadians, on updating the list of comparator countries. So they would remove the United States and Switzerland from that PMPRB7, that basket, and they would add Australia, Belgium, Norway, Japan, the Netherlands, South Korea, and Spain. And I would say finally, but there are a couple of other things that they're planning on doing, but I think that these are the most significant ones. They would require patentees or manufacturers to report rebates and other confidential financial terms to the PMPRB, and the consultation document says that they would use that potentially to regulate ceiling prices of drugs. Interestingly, though, these are the proposed changes. One of the issues that I think we'll get into is we don't know how the criteria would be applied or how the rebate information would be used, among other things, but I'm sure we'll get into that in the discussion. Evolution and key dates. This is not coming out of nowhere. The PMPRB itself had a strategic plan that was predated when it got posted, but back in 2015, that was talking about some of these changes and regulatory modernization. It issued a consultation modernization, a guidelines modernization consultation in June of 2016. Just this past May, as I said before, there was an opportunity, 6-week opportunity for all stakeholders to provide input on these regulatory changes. Again, we haven't seen the text of the regulations. This is more like, this is what we're thinking about doing or planning to do. We have a new health minister in Canada. Health Minister Jeanette Petitpas-Taylor has just taken over from Dr. Jane Philpott. So she is going to be the one who actually carries this initiative forward. We've got November to December 2017 guidelines discussions that will probably happen, and that's where the questions around how the proposed criteria could or would be used, and I understand that the plan is to look at these at the same time as stakeholders will be consulting on the actual regulations themselves. There will be a 75-day consultation period, and then sometime in 2018, we expect Canada Gazette Part 2, which is a fancy term for saying these regulations will come into effect. Now, they might not actually come into effect until 2019, but we're getting a little bit in the weeds now, and I want to hear from the real experts on this, and we're going to start with Wayne. I'm going to pass him the slide advancer. Thank you so much, Wayne, for being here.
Great, thank you very much, Bill, and that was a very nice overview, I think, and a nice way to set the stage for the discussion today. So I'm certainly looking forward to this, looking forward to questions and comments as they come into our discussion period later on. I'm going to back up a little bit. I think as Bill mentioned, there's been a lot of work on this going back by the PMPRB itself, but there's also been work at the political level. When the Trudeau government came into power a couple of years ago now, they issued mandate letters, of course, to all the ministers, We have not yet seen a new mandate letter for Minister Petitpas-Taylor, but I think we can assume it's going to be very similar to the one for Minister Philpott, at least in the area of pharmaceuticals. And that mandate letter included the government's commitment to improve access to necessary medications, to join the PCPA, which of course they have subsequently done, and to make drugs more affordable for Canadians. Minister Philpott took that quite seriously and began a number of initiatives on this front. Last January, she gave an interview on the Fifth Estate on a segment on drug pricing, where she made a very clear and specific statement that she was going to come up with ways to save Canadians billions of dollars on drug prices, and to bring drug prices in Canada in line with what we see in other countries. She specified New Zealand. We might come back to that in a minute, but that gave an indication to a lot of people that she was looking for significant and deep reductions in pricing. Since then, she's acted to implement those ambitious goals, and she's made a number of statements. One that I think is interesting is that back in April, she commented that the reform of PMPRB, in her view, was very important as a precursor to discussions on a national pharmacare plan, basically saying we don't want to lock in high-price medications before we start talking about pharmacare. So again, reinforcing the view that there was a need to significantly lower prices. And then in May, she announced the beginning of this consultation process and made a number of statements alleging that Canadian drug prices are third highest in the world, that Canada spends a much higher per capita spending on drugs than other countries in the OECD, and proposed changes that would, in essence, bring prices down about 25% to the median of OECD countries and result in annual savings of $3.5 billion. And she has referred to that number on a number of subsequent occasions. So we're talking about significant changes. She also announced at that time. She also announced at that time that the government will be working with provinces on a national formulary and some other initiatives. So I'm going to look at some of the, I guess, potential impacts. And again, I don't want to spend time going through the details of the specific proposals as such, but I think it is useful to look at what some of the impacts are going to be. But I think what's really important to remember is if Minister Philpott's policies and objectives continue, the goal is to lower prices in Canada by about 25%. So we can talk about the specific changes to the patent and medicine regulations that have been proposed and the strengths and weaknesses of some of those ideas. But the bottom line is this minister wanted a package of reforms that would bring about price reduction of 25%. That's the goal. And I don't think we should lose sight of that. And even though we need to get into the specifics of how she might go about doing that. But one of the proposals was to require the PMPRB to take into account health technology assessment in reviewing prices of drugs. And there are many questions about how it might do so, and those details are things that wouldn't even be worked out until next year sometime in consultations with the board and stakeholders. But it still comes back to the question of why is there a need for this, given that we already have very sophisticated health technology assessment conducted for purposes of PCODER and the Common Drug Review by CADA. So what additional value would a review by PMPRB provide on this front? So there's duplication is an important, I think, an important issue to consider in looking at these PMPRB proposals. And while it sounds laudable to say we're going to lower prices 25%, what are the implications of that? Has the government made any attempt to try and assess what the implications would be in other areas? of reduction of that kind. What will the impact be on the Pan-Canadian Pharmaceutical Alliance and the current practice of negotiating confidential rebates for public drug programs and cancer programs across the country? Again, we don't know what that will be, but we do know that those programs currently receive very substantial rebates. So what would happen if list prices are reduced 25%? Will they still get the same level of rebate, or will that rebate be reduced accordingly? You know, Minister Philpott made the statement several times that she's going to save $3 to $3.5 billion. What she doesn't say is whether or not that figure takes into account the $1.3 billion that is currently saved by PCPA through the confidential rebates. We don't know how those numbers are calculated and how they work out. So is it an additional $3 billion, or is there some double counting going on there as between the federal government and the provincial governments? Another impact, clearly, of the PMPRB proposals is that the biggest impact is going to be in the private insurance market, because public payers are already receiving much better deals than the list prices reviewed by PMPRB. So what will be the impact for private insurers? That most of the savings coming out of these proposals are likely going to be felt in that segment of the market. And what are the impacts on there? And one of the things we have not talked about at all, and the government has not talked about in these proposals, is what's the impact on the biotechnology sector in Canada. The governments at the federal and provincial levels are both pursuing very aggressive innovation strategies to bring new high technology industries to Canada, increase investments in Canada, and make Canada one of the leading countries in the economies of the future in high technology. What will be the impact on those initiatives of a significant reduction in the market potential that would be available for the results of that innovation? And will we see, as a result of this, will we see delays in the launch of new drugs in Canada? So those are some of the questions. I've set out some issues here, and I think we're going to come back to these at the end of the presentations. But just to keeping in mind, perhaps for now, for consideration later on, but some of the issues I think that are really significant from a patient perspective are the consultations or the lack thereof in this whole exercise, to what extent you as patient groups have been appropriately engaged in this exercise to date. The fact that there really is, on its face, there's virtually no link whatsoever between the PMPRB program as such and payers. So CADTH, PCPA, they do not take into account the PMPRB or deal with PMPRB, and PMPRB in turn does not really address their issues and concerns in terms of the important trade-offs that payers have to make in the funding decisions for new drugs. And as a result, there's a potential for conflict. And then some of the special issues, I'll just raise one right now because I in addition to my professional work, I am currently the chair of the Canadian Organization for Rare Disorders, and so have a real interest in the issue of access to new drugs for rare disorders. And I'll tell you, we have concerns at these proposals with respect to PMPRB that they will have the effect of creating new barriers to drugs for rare diseases. Just for example, with respect to the issue of HTA assessments. HTA assessments are notoriously inappropriate in the case of drugs for rare diseases. And if that becomes a hard and fixed barrier through PMPRB, that could be very negative for the rare disease area. I'm going to leave it there and turn things over to Neil.
Thanks very much, Wayne. Just slides along there. I've been told I have 10 minutes, and I know Bill here is a strict taskmaster, so I'll try and stay within those 10 minutes and get through several slides. Ordinarily, I'd be going into, I think, considerably more detail on some of these. So if there are questions, please don't hesitate to ask them. I know Bill's monitoring the questions as they come along.
And just to remind both Neil and listeners that these slides will be available on SlideShare, so if you have to flip through, somebody can go back and read some of the numbers.
And if you're really good, he'll give you signed copies, right?
Yeah, signed copies from Neil Palmer. Go ahead.
So first thing I'd like to highlight, if we look at this current slide, it's a table of mechanisms for price setting and reimbursement in Canada and what are the current PMPRB reference countries. And you can see from that there's a whole series of mechanisms in place in these countries for moderating or price setting or controlling costs. That includes things like clinical effectiveness, health technology assessment, health economics, things like cost effectiveness, affordability, risk sharing, regional decision making. There's a whole range of things. So there's no one thing in any one country that controls drug costs or helps set prices. There's a whole range of things, and it's important to take that into account. If we move on to the whole notion of international prices in the PMPRB's recommendation, or the former health minister's recommendation to expand the number of reference countries to 12, it's interesting that when PMPRB started this process, they explicitly said that maybe we should be giving less reliance or putting less reliance on international price comparisons, not more. Part of the reason for that is that the listing agreements and the confidential rebates that are in place, not only in Canada, but in most markets around the world. So when you're comparing list prices, it's not very clear, is the comparison appropriate or not. Nevertheless, it still continues in many countries. It stopped in, the UK doesn't do international price comparisons at all. Germany does them rarely. Sweden has stopped doing them, and other countries are looking at putting less reliance on these types of international price comparisons. So the graphic on the right there is with Canada in the middle. The green circles are the countries that Canada directly references, and then there's the blue ones are the ones that reference Canada, and the yellow ones that are all indirectly affected. So you see with just those 7 countries and all the interaction of international price referencing, when we go to 12, of course, that will grow. And each country, each jurisdiction has its own graphic that in many cases is far more complicated than that. When you get into transparent international reference pricing, it quickly turns into a downward spiral because every country is looking for a lower price and starts referencing towards those lower prices, and things go down in a downward spiral. So if there's going to be reliance on international reference pricing, one of the corollaries is it's absolutely necessary to have confidential rebates. Otherwise, there's some very significant unintended impacts. This next slide looks at there's a graphic at the bottom which comes from the 2015 PMPRB annual report. You might wonder where the 2016 annual report is. That would be a good question to put to the current Minister of Health and the PMPRB, but I digress. In yellow or orange, depending on your screen, you will see the current PMPRB reference countries. Canada is in that sort of darkish reddish color over on the left. And then you see some purple dots. The purple dots are the proposed reference countries that the health minister has recommended. The red line in the middle, bar in the middle, is the OECD median. And the recommendation was that prices on average, or that, let me put it another way, that there was analysis done by PMPRB that you would save $3 billion a year if only prices were at the OECD median. And sure enough, when you look at the midpoint of these proposed countries, that midpoint is very close to the OECD median. There's all kinds of underlying flaws in the underlying assumptions that build that analysis. I don't have time to go through that today, but in any event, you can see where they're going. So the question is, well, if you have lower prices, could that delay or even prevent the introduction of products into Canada? And so the question I have there is there evidence that lower prices delay product introduction into low-price countries? And clearly, and I think this is a really important point. The minister and the current minister, the previous minister, these are very smart, intelligent people, but they're getting the information from bureaucrats that, in my view, have an agenda. And we'll go to this slide. This is a slide that was from a tweet that was put out by Health Canada. And this is classic bait and switch. And they say, well, let's look at Canadian prices, prices in Sweden, prices in the UK. Those prices are on average much lower than they are, or quite a bit lower than they are in Canada, 11% lower in Sweden and 18% lower in the UK. and look at the new medicines that have come out in each of these countries. It's about the same. It's very similar. The problem is they're comparing prices of all patented medicines in those countries, between Canada, Sweden, and the UK, but then only looking at new medicines. When we do and look at the prices of new medicines coming in, and only those new medicines that they're referring to, the prices in the UK and Sweden are the same or higher than they are in Canada. So the analysis they're putting out there is not correct. They're as I say, it's bait and switch in terms of that type of analysis. So it's very important that they're held to the standard that if you're going to look at the prices of, if you're going to make the argument that prices may or may not have a relationship to whether and when they're introduced in the country, you need to look at the prices of those new medicines, not the prices of all medicines. And so when we talk about this, is it a theory? Is there any evidence? Well, let's talk about how pharma companies set prices and how they decide in which countries they're going to launch. Launch sequencing is a term that's very well established in the pharmaceutical industry. That says that the process by which they decide which countries they're going to launch products in and the order in which they're going to launch them. And the simplest way to describe it is they launch in high-priced countries first and low-priced countries last. And so the slide I have up there is from a company called SAS. That's not a pharma company. That's a statistical analysis system company. That's a company, it's a very large company that provides statistical software to all ranges of, all types of industries, including the pharma industry. And one of the new modules, or fairly recent modules they have, is this one that will help pharma companies decide in which countries they should be launching their product and in which order, and what the potential return from that would be. And here's a screenshot from this product offering they have. SAS is not the only company doing this. There are literally dozens and dozens of consulting firms and companies that specialize in helping manufacturers decide in the order in which they launch drug products. And this is something I deal with every day when speaking with manufacturers, and they're telling us when they anticipate launching in Canada. We try and understand why. Well, the rationale they give us is, well, if the best price we can get is going to be lower than the price in Europe, then you're going to launch after Europe, and it's as simple as that. And this is, for any important new drug coming to Canada, this is the process the manufacturers go through. So lower prices mean later launches, later availability. The next thing is when prices goes too low, there may be a point where manufacturers are not prepared to sell the product in Canada. And there's a concept in economics known as reservation prices or reserve prices, and that's simply where the price at which the manufacturer is prepared to offer the product is higher than the buyer is prepared to pay. And for the most part, I think in Canada we've been pretty lucky. Most products are available in this country. If you go to New Zealand, that's a different story. And they are not prepared to pay certain prices, and there's no amount of negotiation or anything else that will change their mind. The second component of the New Zealand issue is a budget one. They assign so many dollars to their pharmaceutical budget, and they cannot deviate from that. New drug comes along, if they haven't budgeted for it, it's not there. So price, budget, and reservation is very, very important in terms of what products become available. And I think an important analysis would be a comprehensive analysis of products that are available in New Zealand or not available in New Zealand that are in Canada, and that list is a fairly lengthy list. And finally, I'd like to look at a slide. This is from analysis done by some folks, Anna Hava, Chen, and others, conducted last year. And it looks at the sort of the good, the bad, and the ugly of international or external reference pricing. And I won't go through all of it, but if you look at the lower right-hand corner box, it talks about barriers to access. And I think it's worthwhile to spend some time thinking about the barriers to access that external reference pricing has. And the lower the prices go, there's no question that there's a less availability of products for patients. I'll leave it at there, and we can move on to the questions. Oh, sorry, John.
I don't have any slides.
Oh, you don't have any slides.
Excellent. So pass it over to John Peter to lead us into the discussion and some Q's and A's. As you can see, I've actually put up Wayne's earlier slide that shows a few of the considerations for today's discussion. So, John Peter, what did you think so far in terms of what you heard from Wayne and Neil, or me for that matter, in terms of setting this up? What comes to your mind at first? And then I know I was going to ask you first. Tell us more about Listen. So if you want to jump into that, you're welcome to. But you know, over to you.
Well, I think I have to tell you something about Listen.
Okay.
Because you told me I had to before we started this meeting. So Listen stands for Life Saving Therapies Network. It's a patient-led group, network of physicians, mostly oncologists, researchers, drug companies, people from the HTA world, patients, patient advocates, healthcare economists, former regulators, former heads of payors, the whole panoply of the healthcare system, the healthcare delivery people. And we focused on a simple thing, which is precision medicines and lethal diseases. So what's a lethal disease? It's something that's going to kill you within 2 years with a 95% probability of. You want me to go faster?
A little bit faster. Sorry about that.
I'm speaking so people can understand that. And it also is, so it's a disease that's going to kill you within 2 years. And we focus on precision medicines because they're the only things that really provide hope for people with lethal diseases. Most lethal diseases are metastatic cancers, although there are other ones like Alzheimer's and some of the rare diseases and so on. And we have major purpose of Listen is the following. Within that context of precision medicine and lethal diseases, we are focused on regulatory approval. So we're a coalition that's international, regulatory approval, changing the regulatory approval system so that we can get better access to faster drugs, changing the research protocols so that it's not going to cost as much and you don't have to do, and I won't go into the detail of why it makes sense not to use the normal three-stage descriptive statistic, mostly a big number of studies. But for precision medicine, there are research protocols that are simpler, faster, and make more sense. We're focusing on reimbursement, making sure people don't have to pay outrageous amounts for this drug. When my wife died, one of her drugs cost $35,000 a month. And we're focusing on palliative care for people in precision medicines because they're unique. There are unique challenges. And an overall review and contribution to a global strategy for the introduction of precision medicine. So that's the answer to the first question. What did I think? These guys know a lot more than I do. They were fabulous presentations. For me, the issue is really all about values and basics. So underlying all of these questions is the whole idea of what values drive our decisions. Not what value does something provide, but what values drive our decisions. Are we really caring about helping anybody who's sick get better or get optimal treatment? That to me is the number one thing, and it should drive all these discussions. Secondly, the idea of the healthcare system has to be thought of, in my view, as a whole. So being a former corporate guy, I look at the healthcare system as a corporation. The pharmaceutical industry is one division of that. HTA is another division of that corporation. Healthcare delivery is another division of it. And the economists, and so on and so forth. And the government and the regulation, they're all divisions. And you can't fiddle with one side and make a real change if you're really trying to make real change and trying to really bring, say, reduced prices with good value to the patients, unless you restructure the whole damn thing. So my predilection would be to say, we're tinkering. This is an exercise of tinkering. And the history of tinkering in the regulatory system and in the healthcare system is you add process, you don't subtract process. You add time, you don't subtract time. You add cost, you don't subtract cost. This is going to be, you know, a Rube Goldberg machine. We're going to have HTA and PM, PRB, and all these people sort of falling all over each other and so on. So that's my uneducated, uninformed sort of, but gut feel for how this thing sounds to me. And I have detailed suggestions to make too, but I think we should let other people do that.
Yes, maybe we'll open it up to the webinar listeners. Thank you so much, John Peter, for your initial thoughts. And I think that was building off of one of the comments that Wayne, you made in terms of potential duplicative roles. And so, you know, hopefully we'll see that the next round of consultations will consider all of the cogs in the machine. And Neil, you took us outside of Canada to say that you know, this market is actually part of a global system, and so I think that's really important as well. So there's one listener who's wondering if there are any opportunities for healthcare provider volunteers to get information either to or about the PMPRB, especially on trends, probably to the PMPRB, on trends being seen in the primary care world. So, I mean, what's been in your experience with the receptivity of the PMPRB to listening to healthcare providers and you know, the healthcare system?
I mean, I think there's a fairly large policy group at PMPRB, and they're part of another process known as the NPDUIS, which is an information system. And their policy group, I mean, I think they do interact certainly with the academics. There is, and within the academic world, there are certainly some physicians who are active in primary care. I don't know that they have any direct, you know, with the Canadian College of Family Physicians or anything like that. I don't know if they have any direct interaction with them or in the primary care setting. But they certainly have interactions, for better or for worse, with many academics in the country.
Maybe just add to that as Neil says, there's no mechanisms in place, and they do not go to their way to seek out that kind of input. But nonetheless, if you have something that you think is of valuable information that they should be aware of, that the individuals at PMPRB are usually quite approachable, and it certainly would not hurt to make an effort to reach out to them to share that. But be prepared that their processes and where they fit in the system do not really lend itself too much to that.
We've got some relatively sophisticated listeners today, or participants. One of the questions is, do we have any idea of what the PMPRB quality threshold will be? So, I mean, here's the challenge: unpack the acronym and then prognosticate about what that threshold would be, because I don't think many people on the line actually know what quality is.
Sure. A quality is a quality adjusted life year. It's an acronym for another acronym known as an ICER, or incremental cost effectiveness ratio. And it purports to provide a measure of cost effectiveness, or by extension value. In Canada, and so in the UK, where this really evolved in a significant way, it probably really started in Australia, but it's being used to a large extent in the UK. 20 to 30,000 pounds per quality adjusted life year, an incremental cost, was considered to be cost effective. In Canada, that's over the years translated somewhere between $50,000 and $70,000 per quality adjusted life year. So, but this brings us back to the question: if PMPRB is looking at ICERs, or cost per quality, how would they actually use them? And it's interesting, in the UK, when NICE was asked to try and set value-based prices, they refused. They said their job is not to set prices, and moreover, it's not appropriate to be using qualities to set prices. It might be reasonable to review them, and one of the reasons for that is its uncertainty. All health economic analysis is built upon the clinical evidence that comes out of the clinical trials, plus some additional information on utilities, or some of the outputs in terms of the value to the patient. All of those measures have a degree of uncertainty and confidence limits that surround the measures that come out, which the result, to make a very long answer even longer, is that anytime there's a cost per quality coming out of a health technology assessment agency. It's a range. It's not a single number. And it can be a very wide range depending on the degree of uncertainty, the assumptions, the scenarios, etc. So it's not an easy way to set a price. And so I think PMPRB may find out very quickly that this is, probably not appropriate. It may be a way to say with some confidence that a price really is not excessive, but to determine that a price is excessive, I think will be quite challenging.
I wanted to ask you a question, just to follow that up. Has anybody ever looked at the quality of life years lost?
Or you're referring to almost like an opportunity cost, right?
Well, I'm referring to the human part of how many lives are going to be lost because somebody figures they shouldn't give a drug to somebody because it costs a little bit too much, and they haven't decided to cut some other part of the system to make that drug affordable.
Right, and I've heard of other people asking, well, it takes the 2 years from the NOC, for notice of compliance, to get reimbursed. How many people lost their lives waiting for that?
426 days in Ontario.
Right. So how many people may have lost their lives or had their disease progress because of that delay?
Yeah.
And so I don't know anyone's done that analysis.
I have, actually,
okay.
and I can tell you, but just in terms of getting a drug approved, for every year of regulatory process in the United States and Canada combined, 2.5 million life years are lost. And for every year of regulatory approval process, safety gains are 684 divided by 2, whatever that is, 341. So it's a 50,000 to 1 ratio.
Sure. So to their credit, CADTH and Health Canada both said they're very interested in pursuing parallel reviews to try and move this process along a lot faster.
I don't want to sidetrack it to that, but the analysis stands. If you then transliterate that and move it over to the price range, the price thing, you're looking at how many years in sequencing, any way you want to cut it, you're going to be looking at life years lost versus life years quality gained. It gets to be a very weird equation from a moral point of view.
A weird kind of equation. Also, the kind of thing, quite frankly, that I would suggest are currently and properly conducted by CADTH and through PCPA, where they make decisions about how to apply the analysis on the clinical and cost effectiveness. I don't know how you can set a benchmark based on these qualitative, uncertain measures. So that's a challenge, and it's one that will be subject for more consultations next year as to how they do it. I think the question right now is, should they do it?
Yeah, exactly.
And that's what people will want to address when the Canada Gazette Part 1 proposed regulations come forward and there's an opportunity to consult. I think the question still is, well, why is there a need for this? Bill, you got some more questions there?
We have a couple more questions here. I just want to give one observation. I was stumbling around the internet as I want to do, and I came across a 2012 review of the New Brunswick plan when they were making some pretty significant changes. And it was like an 80 to 100-page document by, obviously management consultant, really thoughtful, and it took a long time to make some of those changes and to bring in some catastrophic drug coverage for the province. In this case, we're looking, I think, at a 16-page consultation document and a couple of other things in the past. This goes back to the first bucket of the discussion questions, and that's around the consultations. A lot of the questions we're getting are pretty fundamental ones, like what is a confidential list rebate? Do you think that the documentation that has been put out by Health Canada and the PMPB to support this has given people enough information to actually respond to it well?
Well, let me make a comment from perspective of court, which I know, which is that in this case there has been no multi-stakeholder consultations at all. And that kind of consultation can be very valuable because you go into a room where you've got the different stakeholders who present their questions, their concerns, their perspectives, and it helps you understand the issues in a much better way so that your own contribution can be much more valuable. Right now, patient groups and manufacturers, for that matter, and other stakeholders in this case, are working in isolation. It's all on paper. There were stakeholder meetings over the summer, but they were by groups. They were very limited and restricted in participation, and they were not a two-way exchange. They were here's what the situation is, and here's we're describing it.
A briefing.
That briefing. And in the meantime, there's been virtually nothing available in terms of consultation. The next stage will be, again, a written consultation on the proposed regulations. So, and unlike in the past, the PMPRB has always had its own policy that it publishes all submissions received. So if you, Bill Dempster, have something to say, you're going to have to go on the public record because we're going to publish your comments in the consultations. And everyone can see them and people can respond to them as they see fit. In this case, all the submissions that were made, and I hear there were over 100 that were made in response to the minister's discussion paper, they're not on the public record, except for the initiative of Neil, who has been able to obtain quite a few of them from voluntary participants, and he's put them on his PDCI website, so that patient groups, including CCSN, can see their own and others' other submissions. But we're really missing that, and one group that we don't see at all are the provincial governments. And I think it's really, they are a key stakeholder in this, but whatever positions they're taking are all being taken behind closed doors.
Can you imagine what it'd be like to be married to somebody who only wanted to discuss things by written submission? I mean, what would you work out? I mean, this is ridiculous when you think about it. Conversation should be a conversation. You're right, Wayne. Absolutely.
I would add to that, Wayne, that not only are the provincial submissions not on the public record, the people that have the ear of some of the provincial governments and the federal government, for that matter, their submissions are not there either. And these are, everything from advocates to interest groups and that kind of thing that have agendas, and we have no idea what they're doing or how they're influencing the government of the PMPRB. So it's also Right to Know Week. You can go to Right to Know. It's a government initiative. They have their website, and secrecy is the exception, access is the rule. And apparently not in this case, but it comes back to my beef about the PMPRB annual report, but also on this, that they should be disclosing these. There's no question.
What is the PMPRB annual report for the listenership that you?
So part of the PMPRB has as a mandate has two rules. One is to regulate prices, to make sure they're not excessive. The other one is to report on trends in the pharmaceutical industry. That's a mandate in the Patent Act. They must report on it every year. And every year, as Wayne knows, as I know, there's a big panic within the PMPRB to get that report written and submitted to the minister no later than the end of May of the following calendar year. So the 2016 annual report would have been submitted to then Minister Phil Pott by May 31st, and traditionally it was always tabled before the Parliament rose that summer, so sometime before June 24th. And in the last couple of years, that slipped. And occasionally, if Parliament has been dissolved or prorogued, then there's no way to table it, and you get that. But in these other more recent cases, it's the minister has decided to delay it for whatever reason, and whether that's being convinced by her advisors or who knows who, but for whatever reason, it's being held back. And the trends that are published there, you saw a slide from I presented that came from the 2015 annual report. They provide very robust and thorough analyses of trends, not only in Canada but in other countries. Now, some people may take issue with some of the conclusions they draw from that, some of their interpretations, but the numbers are the numbers, and it's very important that people have access to those. And again, this time they've delayed it significantly. They could have published it in June. Again, in July and August, there were opportunities. And again, here we are in September, and it's still almost October, still not published. They have 30 sitting days to publish it, but it looks like they're dragging this out. And I have no idea if you change the ministers, it'll be another 30 days. We'll see.
So just a quick question from somebody listening. Given all of this, and Wayne, I thought you brought it up and put it really eloquently in terms of the types of consultation and engagement to date that have happened from CORD's perspective. What can either individual patients do or patient advocacy groups or other stakeholders do to get involved or to share their thoughts on this?
There has been this thing that was sent in.
Actually, JP, why don't you, you know, I mean, your participation today on the webinar, I would argue, would be one example of how patient groups can get involved in it.
Oh, well, there's two patient groups here.
That's correct. We've got Cord and Listen. Thank you. And of course, we're being hosted by the Canadian Cancer Survivor Network.
There's three of us.
Great.
Probably 2 or 3 listening, so maybe we're going to have enough for a baseball team.
Yeah, I mean, one of the questions was, how can healthcare practitioners, you know, give information on trends? And I thought that was good into staff. But I mean, what else can individual Canadians or their associations do that maybe haven't been done today?
Well, one thing I think is to bring these concerns to the attention of elected officials, and I don't mean simply to attempt to write to or see the federal minister of health, but also the provincial ministers of health as well, because they all have important input in this. And I think to a very large extent, the federal government is going along assuming that they're doing this for the provinces. But that's not necessarily the case, and it may not be perceived that way. Some people ask, well, why did Minister Philpott want to take this initiative? I think the simple reason is it's the only tool that she has available to deal with drug prices. It's a totally federal power that she has, and so she can do that. Everything else that she might want to do, she has to negotiate at the FPT table with the federal, provincial, territorial health ministers. She has to negotiate, and she's just gone through a year of health transfers discussion, right? And we all know, and there are a lot of other important issues on health ministers' plates today. So this is something that she can do on her own, and she thinks she's giving the provinces something, and it doesn't cost her anything, right? It costs her nothing, except a few more officials to run the system. So it's something that it makes it very attractive for her. But what are the downstream consequences? What are the negative consequences? So patient groups in particular have an opportunity. If you have concerns about some aspects of this, as some of us have, then we should be bringing to attention of provincial ministers as well as the federal government and even our own local members of legislatures.
Thanks. We've got one final question because we're coming down to 2 o'clock. I mean, there are lots of other questions that have been put in, including do I have time to get a glass of wine? Some very good questions that are in on the webinar. But I think this one's pretty important because it's talking about the public drug programs and what they're able to provide. So the NIHP often only offers medications that are cheaper alternatives, but very ineffective and in terms of dependency promoting, probably with reference to opioids there. Is there any discussion about this, the NIHP, and addressing it along with mainstream Canadian Health Pharmacy Alliance? I think that's reference to the Pan-Canadian Pharmaceutical Alliance. Any thoughts there? I mean, just in terms of the challenges of one of the public drug programs that she's mentioning, what is the relationship between what the PMPRB is suggesting to do and the public drug programs? Let's start there.
So, and Wayne mentioned it earlier, there's very little relationship there. I think they're collaborating, I don't even collaborating is the right word. They're speaking to each other, communicating much more than they did, but there's no official linkage between anything that the PMPRB decides and any particular drug plan or the PCPA, the Pan-Canadian Pharmaceutical Alliance. They are the drug companies, the drug plans to a certain extent, or the PCPA are relying on PMPRB analyses from time to time, but they certainly aren't, collaborating in any kind of active way. And to that, to the question itself, I think that is outside what PMPRB is looking at. But I would say that the work that the jurisdictions, federal, provincial, territorial, including NIHP, which is a federal program, they are collaborating and coordinating much more, and that you'll see a great deal more coverage that is harmonized across the country through coordinated not only health technology assessment, but also through the PCPA process.
Can I ask a question?
Of course.
Simple. For both of you guys. And you can only answer it with Wayne, with half of you, because half of you is a patient advocate. So what is your, to me this is the Tower of Babel we're talking about here, but people talking different languages, protecting your territory. do you have hope? Is there a reasonable hope in your heart, Neil, that, or in your mind, or wherever your hope lives, that there is going to be coming together, a collaboration, a cooperation that's going to work its way through all these things, PMPRB aside, all give the whole, in a holistic kind of way?
I can tell you, I am really encouraged by how well the provincial drug plans and the NIHB are working together. In fact, it's absolutely remarkable to see at that level within government the level of collaboration and cooperation that goes on. Now, they are not the decision makers in the minister's office. The ministers have given them the go-ahead to do these things. But I deal with these folks every day, and it's remarkable how well they are working together. It should be a case study in public administration about how well you can do something without having to, pass laws and that kind of thing. It really is remarkable. Where is the hope? There's going to need to be sufficient funding and I think policy direction to say that access to these technologies, and it's not just pharmaceuticals, we've got gene therapies, cell therapies, all these other things that are coming, that needs to be a priority, and the funding needs to be in place. Are prices too high now for drugs or for some of these things? Perhaps, and there's ways of looking at that. That's part of PMPRB's role, and that's what they should be focused on. Health technology assessment, CDRP code or INES in Quebec, looking at cost effectiveness and value. All those things have to happen, absolutely. I'm really encouraged by the way the provinces are working together. I'd be very concerned if someone tried to break that apart, because I have no idea what that alternative would look like.
And Wayne, what's your hope or
non-hope? Well, first of all, I agree completely with what Neil has said. I've never seen anything like this in terms of the cooperation among, collaboration among all these governments today. And when you think about it, it's tough. It's tough getting all of them together and to agree on things. So they're working really hard at it, and they deserve a lot of credit for that. Just coming back, I think I may have even put on one of my slides there that one of the priorities of the federal health minister has been to work with the provinces on a national formulary. Now, I don't know what a national formulary means, and they've been talking about it for 25 years. But nonetheless, she's put that forward again as a priority. And I put that in the context as well of the report that came out today for the Parliamentary Budget Office on costing the pharmacare, national pharmacare program. I think politically, look what's happening in Ontario with OHIP Plus coming in January 1. I think politically we're going to see more and more discussion about national pharmacare or some kind of approach to national standards for pharmacare over the next couple of years. And that's where the real action, I think, is going to be. And we're, again, as put on my patient organization hat again, JP, but where we really need to focus too, because we all want to improve access to medications. We just want to make sure it's a good program. We don't want a New Zealand model,
that's right,
which keeps us from getting access to important new therapies. Right. So whatever it is, however it works, as long as we can ensure that patients' interests are being represented and reflected in the program, that's a key objective.
And I wonder, Bill, what's your hope?
So my hope is to get through this webinar so that
get that glass of wine.
Yeah. No. I think my hope is that and we're getting to it. That we have more conversations like this that look at things, as you were saying, JP, from a holistic, systems-based approach, and I'd love to welcome a forum to actually unpack that and to say, okay, is it going to happen at the provincial level? Is it going to happen at the national level? I was on a call a couple of weeks ago with Kaiser Permanente, and very vertically integrated health system in the United States. It's extremely efficient, and it does right by its healthcare professionals and the beneficiaries. It's a federated model. But it's still a corporation, and it actually has different jurisdictions that actually have leeway to do things differently. My hope is that Canada can do right by Canadians, and that might mean that Ontario has different models for its different populations. It's not a one-size-fits-all for everybody, because that's the other side of my hope. My worry is that we're going to have one standard approach for everything, and the people on the edges are going to lose. But my hope is that we're going to be able to look at this from a holistic perspective and figure it out and not rely on platitudes and rhetoric to drive policy, but we're going to be able to really do proper think-throughs before we move forward. So that's my hope. We need good management consultants and thought leaders like you, JP, and Wayne and Neil. And I want to end it actually with two things. One, to give a shout out to one of our listeners who puts forward the question or the comment that this might only lead to one line of cancer therapy in a given situation being reimbursed. So that from what she heard, this is one of her concerns with the Cancer Survivor Network. But I want to turn it back and leave it to you JP, to have the final word and ask you what's your hope, and then we'll close out the webinar, recognizing that we've gone over time. We rarely do that, so thank you so many people for sticking around. JP.
Well, I don't know. My hope is that something changes before I die, and I'm 75 years old. So, and I've had cancer. I lost my wife to cancer. I work with people who die from cancer all the time because I specialize in lethal diseases. And Kaiser Permanente is a very interesting example because they're values-based. They're physician-driven. They're started by a bunch of people who want to provide better care at reasonable prices. But my hope is that we give our head a collective shake, and we stop being so bureaucratic, and we stop being so rule-bound, and we stop being so driven by economic analysis, cost-benefit analyses, forgetting people exist. We start looking for real savings, and we start, because there's so much savings in the healthcare system right now, if you wanted to take it, to apply it to where it could be, that we start making rational decisions about how drugs come to market, how you incent drug companies to bring them here, make coalitions with other countries. There's all kinds of ways to do this. My hope is that somebody shakes their head, somebody younger than I am with more experience, more energy rather, and more life years left to actually make this happen, because we need to shake this up. It's a mess right now.
Thanks very much. We'll close on that. Thank you, Chad. My apologies to everyone who missed their appointment at 2 o'clock, but this will be archived, slide shares up. We made reference to a couple of reports, and so, Chad, I might actually get you a couple of links, including PDCI's sharing website, the Parliamentary Budget Officer's report from today on national pharmacare costs, and we'll put up the link to listen. And so thank you, all three of you, for taking the time today to participate. Back to you, Chad, and then I'll stop sharing.
Yeah, so obviously I'd like to take this time to thank you, Bill, John, Peter, Neil, and Wayne for joining us today. Stay tuned for our website, or stay tuned to our website, survivornet.ca, and sign up for our e-letter to make sure you're aware of future opportunities to join our webinars. And just as a reminder, this webinar will be available online tomorrow with a full video on YouTube, as well as the slides on our SlideShare account. Links to both will be sent out tomorrow afternoon. So thank you all for attending, and we hope you have a wonderful afternoon.
Thanks, Chad. Bye-bye.